Okay.
Hello.
Hi, there you are.
How are you, Dr. Nan?
I am delighted to see you, Kristen. Here is Lemore.
Hi,
Hi, Lemore.
so
And
good to see you.
yeah, I was having a little technical problem this morning with my let's see if we have Maureen looks like she was on before. Let me see if I need to invite her again. I'm gonna invite her one more time.
Okay.
Okay, so good
Good
morning.
morning. I'm so happy to be here, and it's great to meet you, Lemore.
Really nice to meet you, and I'm so excited for our conversation
Me
today.
too.
The
Me too.
way I've been thinking about this talk, there's a problem with Maureen. Okay, let me try and invite her again.
Sure.
Is everything you wanted to know about the pelvic floor, but were afraid to ask. It's like the doctor. There she is.
Hi.
So I was
Hey,
making a
everybody.
joke. Everything you wanted to know about the pelvic floor, but were afraid to ask. That was a Woody Allen. Everything you knew about sex. I think the pelvic floor, we need to know a lot more about it. So I'm going to turn this over to the medical people, Maureen and Kristen. Go for it.
Oh,
Good
good
morning.
morning, Maureen.
Yeah, we're super excited for this topic today because I feel like in some ways pelvic PTs, as we tend to call them in the US, or pelvic physiotherapists, are literally so helpful to me as a gynecologist who specializes in sexual medicine. But they're useful for lots of things that people aren't even aware about. And when I go to talk to patients and say, you need to see pelvic floor PT, they're like, what? Are they going to touch me like that? And I'm like, yes, but they're going to make your life better. So I'm super excited that Kristen's here today. And I'm so excited that I brought my pelvic floor model.
Good for you.
Because I got tired of trying to explain how the bottom of our pelvis is just a ball of, like a sling of muscles that all of your little tubes go through. So I ended up like buying one so that I can show people exactly what we're talking about, which is this fabulous thing. But so Kristen, why don't you tell us a little bit about pelvic floor muscle, what it is? Everybody has one, right?
Yes.
Even men?
Yes. I'm so happy to be here. And this is the topic I'm most passionate about in my life. You know, my friends, family, boys, I have two boys, will tell you that I can weave the pelvic floor into any conversation. So I appreciate the opportunity to talk. And before I dive right into the pelvic floor, I'll talk a little bit about my personal experience to becoming a pelvic floor physio, which honestly, I hear in the clinic all the time. And so I was a physio for over 15 years before I had my first son. And the pelvic floor world has really started to become much more visible, I think, to people. So as a very, new mom, 2 weeks after having this little guy, I decided I was an avid runner. I was going to go to the gym and jump on a treadmill and run. And lo and behold, I was like, wow, I am sweating a lot, and then realized, oh, that's not sweat, right? So sometimes for people, it is when things are not going well that then we go, oh, what is happening in there? And that might be incontinence. It might be pelvic pain. It might be chronic constipation. It might be erectile dysfunction. It might be that I have all kinds of urgency and I can't run to the bathroom in time. And all of a sudden, then you think, oh, what is going on? And what is happening within my pelvis? And then you start to dive in, and you might see an amazing gynecologist like yourself, or you might see a urologist. You might talk to your family doc, or you might come and see we call them pelvic health physiotherapists, you call them pelvic PTs. But that's is the world that we live in. Peeing, pooping, pain, sex. That's me. So, yeah, so that you asked about the pelvic floor, and we think about the pelvic floor like this really nice hammock of muscles that runs from the pubic bone back to the tailbone and out to your sit bone. So as anybody that's watching, or as you sit, if you even rock side to side, the piece that's kind of holding that pelvis together at the bottom is your pelvic floor, and has lots of really big functions, ones that we've chatted about already: peeing, pooping, pain, sex. Those are the things that the pelvic floor can help with and can help keep you continent. It can help support your core. It can help support your pelvic organs, and it can help bring you pleasure. And then if it's not working, then we get into all the other stuff, right?
Not working, it brings you misery. Let's be honest. If you're incontinent of urine, if you are like incontinent of stool, if sex hurts, which is not necessarily like always it's actually kind of the opposite. It's not like a low tone problem, but all of those things are horrible to human beings, right? If sex hurts, if you can't hold your urine. So you guys are just instrumentally important in helping people kind of recover some of that like function so that things function the way they're supposed to. And it's so funny that you're like the world's best kept secret. So I'm glad that things are getting kind of changing enough that we are now aware that, you know, literally everybody should. And I'm interested. And I know Limor is too, that like we really should probably pay more attention around pregnancy and childbirth with the pelvic floor, not to like, you know, walk away from sex. But
by the way, this is when most women find out they have a pelvic floor, and mostly after they have given birth and they've experienced things like what is it called when it called a prolapse?
Yes.
Yeah.
Mm-hmm. Yeah. So what other kind of things do you see? So just so everybody's aware how vitally important our pelvic floor is. So there's a bunch of dysfunctions that we tend to see, right? And it's not all just sex stuff, although that's kind of my favorite area. You see other things like low back pain or hip pain can also be affected by this, right?
Yeah, 100%. And I love the conversation about the fact that we all have a pelvic floor. And so pelvic floor dysfunction can start as early as like young, like babies, toddlers, teenagers. So when we think about what the pelvic floor does, if we, you know, it's not as cut and dry as this, but we can look at it where it has kind of low tone. So think about, I always tell my clients, think about a cardboard box. So the bottom of the box is the pelvic floor. The top is your diaphragm, that big breathing muscle. Then you've got your abdominals and your back muscles. And that's kind of what controls your inner core. So if you have the bottom of the box, you take that box, you dip it in water, and the bottom of the box bows out. It becomes really weak. The core loses stability. That's what we call like a low tone pelvic floor. And with that, we often see incontinence in our children and people of all genders. We see in people who identify as women, we see pelvic organ prolapse. So that all prolapse is dropping down of pelvic organs. And we know that it happens in 50% of women. Like that in itself, when you're blow your mind. You're right. So it may not be that prolapse is going to be really symptomatic, but if we as a medical provider go and look for it, about 50% of women may end up with some prolapse. So that's that low tone pelvic floor. The opposite might be where you take the bottom of the box and you crunch it all up. You make it really tight. And then you can understand that would have implications on the rest of the box. Like the front pulls in, the back pulls in. That is our high tone pelvic floor. So there's more resting tension in the muscle. That is often associated with pain. It might be back pain. It might be pubic pain. It might be groin pain. It might be pain with sex. But it also, weirdly, might cause incontinence or leaking pee because a really tight muscle does not work very well. So, and in my clients, I'll say to them, you know, think about somebody who's had a stroke and they have all kinds of contraction and tightness in their arm. They have tight muscles, but the muscles don't work very well. And that's what that high tone pelvic floor is. And that can start as early as little ones. Like if we have a little baby or you know, a young child who has just learned to toilet train. What is toilet training? Toilet training is getting kids to withhold or control or contract their pelvic floor. And if that goes a little off the rails, they can end up in constipation. Constipation is particularly in young girls can turn into pain with intercourse, pain with insertion of a tampon because the pelvic floor holds too much tension. And then we see that myriad of things that happens along the lifespan. So Limor, you're right. We often see that people start thinking about their pelvic floor around the perinatal period, but it is my aim to back that conversation up to what's happening in childhood and how do we set ourselves up for success all the way through.
Yeah, no, interestingly, clinically, some of the most tense pelvic floors I've ever seen, and have been in athletes, specifically like gymnasts or figure skaters, pole vaulters, like people who just do need incredible balance and core strength. I have found some of the most, like, it's almost like you can barely even examine them. There's so much hypertrophy of some of those muscles. Do you see that too? Because like these people are like inadvertently like, what happened? I can't have sex, but I was training for the Olympics and now I can't do anything.
Yes.
Yeah.
Resoundingly yes. So gymnasts, figure skaters, horseback riders. I have a little 13-year-old who does jump rope and horseback riding. And so she has in younger teenagers, we don't typically do internal assessments as a pelvic floor physio. However, we can use diagnostic ultrasound to see what's happening with the pelvic floor. We do a lot of feedback. And in this little one, it isn't so much that she has pain, but she has so much overactive bladder. So she's peeing. In my first assessment, I had her in the office for 45 minutes and she peed 4 times. So that's the other thing. Yeah. So that's the other thing, that tension can cause not only pain, but all of these bladder and bowel symptoms. And so we call ourselves pelvic health physiotherapists. We spend a lot of time thinking about the pelvic floor, but certainly we talk about bladders and uteruses and rectums and the impact on digestion. And so thinking about that really tense pelvic floor, that overactivity, we're doing so much discussion about how do we reduce tension? How do we delay voiding? How do we extend time in between going to use the bathroom so we can allow that bladder to stretch a little? And this conversation we have in adults and children all the time.
Yeah, so for people who don't know, Kristen is in Canada. Lucky Kristen. And she also has a podcast, and we'll talk more about that later a little bit, called The Whole Shebang, but it's written the way you want it to be written if you're interested in sexual health.
Yeah.
So those are physical kinds of things that cause some of the pelvic floor tension. Given that we all live in the US, and given that we all are extraordinarily stressed recently, can you tell us a little bit about like emotional, kind of psychological stress? Can that affect your pelvic floor?
Yes. Can I swear on this?
Yes.
Please do, as much as possible.
I'm a Canadian and I have to ask permission first.
You're Canadian and a woman. No more asking permission. Just do it.
So when we think about stresses that are placed in the pelvic health region, you're right. We can talk about physical stresses. We can talk about hormonal stresses. We can talk about emotional stresses. And emotions, we know, cause all kinds of disruptions to how the pelvic floor muscle is working, how our digestion is working, how our rectum is working, which is why the saying scared shitless exists, right? Because there's a physiological reason to that. When we are scared, we're in that sympathetic nervous drive, so that fight, flight, freeze, things go a little haywire. And so you're 100% right. We see that the pelvic floor holds way more tension typically when people are highly scared, when they are anxious, when they have depression, or when those emotions are really, very prominent. And that in itself is interesting. It's like this circular, right? I'm really stressed. So, if I think about when I was a young grad student and I had to give my first presentation at a national conference, I ran to that bathroom so many times before. I had, low back pain for the week before. And I think back now, I think, oh, my pelvic floor was holding all this tension. And then you think about that, in a bigger scale. So somebody that is under tension for a long period of time. So that pelvic floor holds lots and lots of tension. Maybe they have difficulty fully emptying their bladder, fully emptying their bowel, and sex is quite painful. The longer that lasts too, those type of things like difficulty with peeing and pooping and sex in themselves cause so much stress. Then the stress is higher, then the pelvic floor holds more tension. It's this terrible downward spiral that it is one might contribute to the other. But I mean, we know that in people that have depression, that have pelvic floor dysfunction, they have a 30% chance more of depression, that they have 20% higher chance of being anxious, and that actually doing something about the pelvic floor can reduce the depression and anxiety in itself. Wow. So not to say that my psychotherapists and my psychiatrists and my counselors are not incredibly important to this, but addressing the pelvic floor issues sometimes actually helps with those psychological issues that people are expressing: depression, anxiety, stress. It's nuts, actually. Yes.
Kristen, can you talk about the pelvic floor and the penis?
Yes, I absolutely can.
I see we have some men joining us.
Yeah, that's fabulous. Yeah, so pain, when we think about what happens to the pelvic floor if you have a penis, you might find that you have rectal pain, testicular pain. You also might find, one of the things that happens when we have an erection is the sum of lots of things. We need our nerves to be working. We need good blood flow. We need to be in the moment, all of those things. But we also need our pelvic floor to fully contract and hold the blood in the erectile tissue. So if the pelvic floor isn't functioning very well in someone who has a penis and they're trying to have a good erection, what they might find is that they sustain an erection, but it doesn't last very long, or that they're unable to orgasm or ejaculate, or, worst case scenario, that they can't actually maintain an erection at all. So we have the pain things that are happening. We have the impact sometimes on ability to have a substantial erection and to climax. We also see in men too, post-radical prostatectomy, that they have lots of urinary incontinence, and so that sometimes the things that we have fantastic urologist partners, but sometimes they're a little scant on details, and men will come into my office and they'll say, I had cancer, now I don't have cancer, and that's amazing. However, I'm leaking every time I sit up, every time I stand, when I golf. I can't maintain an erection, and my penis is shorter. Because as they remove a piece of that urethra, then the penile length can shorten, and it's a surprise to many men. And so some men in my office will say, like, if I really knew all the things that might happen, I don't know if I would have proceeded with this procedure. Yeah. There are lots of good reasons to do it, but it is good to know what the outcome might be. And the stress of that then means that anybody that leaks pee of any gender, the first thing you're going to do is try and tighten the muscle and hold tension because you're afraid that you're going to leak. And that tightening in itself can actually make things worse. So we want muscles that contract. So I always say, you got your pelvic floor, that's the hammock. It contracts up and in like a jellyfish, and it relaxes back to a hammock. So the other cue I give, because my company is called Blueberry Therapy, is pull a blueberry up and in. That works well in people who identify as female, but in men, they're like, what are you talking about? So we say in men, pull the turtle's head into the shell, bring your boys closer to home. We use different cues.
How do you check a man's pelvic floor?
Oh, we go right up the bum.
That's what I figured, but But I was just,
Yeah.
can I talk a little bit? First of all, somebody said, how they think is cortisol involved? How does cortisol work on your pelvic floor?
Yeah, 100%. Yes. So when we are in higher stress situations, the cortisol is elevated, and that changes so much in the brain, as well as the messages that are going to all your pelvic floor, your bladder, your bowel. It changes ability to lubricate in those that have a vagina. It changes all of those things. So if we think sympathetic nervous system, fight, flight, freeze, versus parasympathetic nervous system, rest and digest, we want to bring that cortisol and that stress level down in order for us to do all those good things that are more in that parasympathetic nervous drive.
Before we talk a little bit more about that, I just want to make the point that, like, as a medical provider and someone who does sexual health, both counseling and medically, we see a lot of physicians not counseling people about the side effects of potential treatments, surgeries, like thoroughly, especially where sexual health is involved. And the more research I'm doing about like trying to educate providers about sexual health, and the more patients I see, the more I realize that like it's completely left out of surgical discussions, radiology, like radiation oncology. I have seen several women whose vaginas have been destroyed by radiating their colorectal cancer. So all of those things deserve the attention that they get. So I'm not surprised that you're seeing people who are like, I wouldn't have done that if I'd known. Because there's usually more than one way to treat a cancer. Sometimes there's not. But the thing is, like, we need to do a better job of educating patients about the side effects, including sexual side effects of medications, surgeries, radiation therapy, like all of those things, because they're really detrimental. And some of those things you can't get back. Like a radiated pelvic floor becomes a hot mess, and it's devastating to women.
I'll pass it right to you, Nan, after this, but like that is so true. And when I think about, I had a lovely, lovely individual who was pregnant. They found breast cancer, found that it was quite an aggressive type of breast cancer. They induced early. Baby was great. Went right away and did a single mastectomy in this particular person, and chemo and radiation. Now, nothing in terms of radiation near the pelvic floor, but just the chemo threw her into early menopause.
Mm-hmm.
And she will say, of all of those procedures that she had, the mastectomy, the chemo, the radiation, the thing that she called it suicidal pain was the anal fissures. And she was not having intercourse at all because of so much vaginal dryness. And those are the things that, like, she was treating the cancer, and there were all these sexual and, at the end of the day, rectal things that came up that were so problematic for her.
Yeah. I know, it's awful.
And Nan, I
gotta do a better job.
Yeah, I cut you off, Nan.
Well, what I was going to say in regard to Maureen's conversation is we learned at ISHWSH, the International Society of Women's Sexual Health, which Maureen and I will be at next week. Are you going,
Friday.
Kristen? Are you going to ISHWSH?
I'm not.
Not this year. And I want to make sure you talk about your conference before we get off this call, because Kristen has got a great conference that's going to happen in May. We learned that they just, up until very recently, haven't even had the maps to protect the female pelvic areas from radiation. So
they were completely like oblivious to the amount of spread that the radiation for the colorectal cancers was giving. And when you've got a tube that's the vagina, and it's very close, and depending on your age and childbirth and your genetics, like the tissue in between, that perineal tissue, can be very thin. But the spread, the woman that spoke a couple of years ago was like, I was the first person who ever even looked at this, and I was dumbfounded that there's not a single piece of literature that exists about like controlling for the damage that goes on beyond treating the cancer itself, and like limiting it but being effective.
So
it was
these
shocking.
maps for men.
Yeah.
And that's the standard of care, and they've ignored the differences, the sex differences.
Yeah.
And I do have to say my pelvic floor is very tight right now. When I'm thinking about what's happening in this country,
Yeah.
I am just, so I'm good. But I want to shift it to pleasure for a
Yes.
minute. Okay. I learned a little bit about my pelvic floor, obviously, when I was pregnant because I did Kegels and all of that. But you know where I really met my pelvic floor? In advanced yoga classes where they have you do something called Mula Bandha, which is doing the breath where you pull up on the floor of the pelvis and then you release it. So here's a side effect, a positive side effect from my practice of yoga was all of a sudden after doing this kind of yoga with these breaths in the floor of the pelvis, I started to really just bloom. I had my first just thought-induced orgasm on a dance floor after that. I started to experience pretty easily multiple orgasms and I wasn't trying. I'm not saying we should strive for this. So what I've done is now this is not my wheelhouse in terms of the pelvic floor, but when I work with clients in order to really help them ground into the restorative nervous system, is I teach them how to do those energy locks. And what's interesting about those energy locks is that I think because you're bringing more blood flow, like to the pelvis, that a lot of people find that not only are they the people who have penises, saying that they're able to have erections that stay longer. People who have premature ejaculation report, and I've seen some support in the literature, that they've learned more ejaculatory control with and through, I think it's the combination of the breath work and sort of activating, so tightening and releasing those muscles. So, I think I'm going to be doing a whole lot of mula bandhas now.
Diaphragmatic breathing, right? Isn't that the thing that a lot of
It's
people just don't do?
It's really the ability to really, first of all, the longer exhalation. So if you want to do one thing to change your nervous system is extend your exhalation, because what you do is you trigger the vagal brake, which tells your body in that moment, oh, I'm safe. It slows the heart down and it really does give you, if you practice this. So I'm telling everybody, if you're feeling stressed out here in America, that we're going to need to keep ourselves very grounded. We're going to need to be able to, like regulate our emotions. Getting activated, is really not healthy for us, nor does that empower our activism and our resistance. So long, smooth inhale, and then just extending the exhalation a little bit longer. Your body will then switch into the restorative tone. And if you feel yourself tense, your pelvic floor, your shoulders, just let that be the cue to take that long, smooth inhale and the longer, smooth exhalation. So it's kind of funny how that practice can help people who have also compulsive sexual behaviors. I've seen that it's almost like balancing, and maybe what it's doing, I don't know if anybody's ever studied this scientifically, like what happens in the pelvic floor and the nervous system when people practice these energy locks. I'm imagining because you're tightening and then you're loosening, you're creating some more balance. Would that be a good hypothesis, Kristen?
Yeah, and actually it has been studied. So it, particularly with yoga and yoga breathing in the pelvic floor, there's some really nice evidence to show that the deep breathing, using the diaphragm to, and using, what you're counseling is perfect. That nice deep breath in, using the belly, nice slow exhale, instead of what, when we get into that fight or flight, we do the little bird breaths up here. They're like, we do not want to do those. So that deep belly breath, nice and slow exhale, helps with nervous system regulation. It helps with digestion. It almost is that like pump on the actual, the GI and the whole gut system gets a little bit of help through that deep breathing. And we actually can see even 2 minutes of deep, slow breathing can help with both pelvic floor activation as well as pelvic floor relaxation, and we need both.
I am familiar with the research on the yoga itself. What I was referring to, if anybody ever studied when you're actually doing those mula bandha, the energy locks, if they've ever added it to that. But you know what? It's good enough that we know that the yoga breathing works. So I'm happy with that.
I'll go back and look. I will go back and look, but we know it helps, right? And I mean, even there was a big review looking at what are the things that you can do if you are a pregnant human going into delivery to reduce your pain. And one of the ones was practicing yoga because of the breaths and because of the ability just to like slow everything down and let that pelvic floor go, especially as you're going into labor when that is a particularly anxiety provoking moment, right? So yeah, the breathing is so important, and we talked about on the whole shebang, Nan, and it's really neat to see across the board when we look at mindfulness to improve sexual desire, when we look at how to improve pleasure, how to reduce tension, breathing and doing really good deep belly breathing keeps coming back, and it's just really important.
So if you balance your nervous system so that you have access to that restorative tone rather than walking around in flight or fight or freeze, we're going to be able to navigate this next leg of the journey together. We need to stay positive. I'm really doing a lot of trying to actively cope with what we're experiencing here in the States. Can you tell us about your conference?
Yes, I would love to. Before I say that, you can keep working or you can move to Canada.
I'm thinking it might not be a bad idea, but I don't know. I got my roots here, got my kids here, but it's crazy making right now for us. We have to really stay positive, strong, and resilient and do what we can. Vote with our wallets, start boycotting. There's a lot of good things we can do. So when we're coming up to Canada in May for your Pleasure Principle Conference.
That's right. I'm so excited about this. So this has been many years in the making. So Friday, May 30th in Hamilton, which is not too far from the U.S. border, Buffalo, Rochester, is not too far from free. It is going to be a one-day conference that we're talking about pleasure and about advancing women's sexual health together. So what happens around the perimenopausal and menopausal period from a gynecological standpoint, from a naturopathic standpoint, pelvic health, what happens with women who have endometriosis and sexual pain? What is the gender gap as it pertains to orgasm? What happens to our seniors as they age? And what does sexual intimacy look like there? I'm just absolutely thrilled that it's happening and so excited for that date to come. Literally to come.
It's amazing. Yeah, we don't know enough about this, especially also going into perimenopause and sex in older age.
Yeah, for sure. And I mean, again, I always go back to that lifespan approach, so when you talk about emotions and how they impact the pelvic floor, a few of my clients come to mind. So I have a little guy who was completely toilet trained and was doing really well and making it through the night. And then all of a sudden he started wetting the bed. And that came along at the exact same time as his parents had another sibling.
Yeah.
Right.
They call it like the regression, right? But it's not normal, actually.
That's not normal.
Oh,
I mean,
wow.
So we call that like secondary bedwetting or secondary enuresis, which is wetting the bed at night. But it often comes around for kids during times of change in their life. A new sibling, starting school, a change in the family structure, all of those things. So I think about that. I think about my young mom who had a very traumatic delivery, and every time her child cries in the room next door, she has pelvic pain. right? Like that is just that sensory stimulus, the reminder of that traumatic moment when she has pain. I think about, you know, my gentlemen who are unable potentially to have an act like a really decent orgasm, a really good erection. Some of them, you know, spiral into like so much tension. Now we're having leaking, getting up at night to pee, fall into this overactive bladder stuff. And I mean, it comes from the stress of something that's really impactful to them. So there are many points through the lifespan, age and gender, that the pelvic floor needs to be addressed. And some of the things, like, it's so neat when we talk about perimenopausal women. There was a great study done in Iran where all they did was that they brought a bunch of women together. They talked to them about what's happening in your body, what is happening in your pelvic floor, and they did this scale where they looked at orgasm, sexual satisfaction, and stuff before they did it, this conversation. Then they also talk to them about how to contract your pelvic floor. And at the end of that, they follow these women just with knowledge, with information, with understanding of how your body works. Many of them had higher levels of sexual satisfaction, higher levels of ability to orgasm. So these conversations are so important, and they themselves can actually impact what happens to people going forward. And so, you know, that's why I'm very excited to be here.
Just the conversation alone, when you give people permission, there's a model in sex therapy, information. And
Yes.
sometimes that's just enough, you know, and I think a lot of times people forget that they have a body. They're in their head so much. And I do want to say something about that conditioning. So the woman who had that awful delivery and just the cry of the baby elicited the pain in her pelvis. That's conditioning. That's classical conditioning. And this also happens a lot with men. Not that they're they're not having bad childbirth. But what I notice, a vast number of men who come into me because they're having erectile dysfunction, they've had one or two instances where the penis has not been cooperative. Then they start to become anxious about the penis. Is the penis going to work? Their partners get anxious about the penis is going to work. And it snowballs into this big thing where they're conditioned to have the stress response, which is not good for your penis. Because when nature is equipping you to run from a danger, you don't need blood in your penis. You need blood in your skeletal muscles. So the enemy of a nice erection is too much anxiety or stress. A watched penis doesn't fully erect. A watched orgasm doesn't happen very well. So just being able to recognize, I think when I give men the information, oh, actually this is kind of common. It is common that men who get worried about their performance then have instances where their penis isn't being so cooperative. Then it becomes a thing and it snowballs. So, learning can go either way. Learning can make it harder for us to function if we're making these associations, and there's a lot of anxiety around functioning and around actually performance. So good sex is sex where you're in your moment, where you're connected with yourself, and when you're connected with your partner, penises will wax and wane in terms of how erect they are at any moment. And I want to go back to the kid who wets his bed, after a sibling. When you say kind of, is it normal? What I think we could say, is it common? Because it is common when a kid experiences the addition to the family of a sibling for them to have some anxiety. And it's also common when kids make developmental leaps in one way for them to kind of go backwards in another way. I think it happens to us adults too. So I'd like to make that distinction between normal and common, and understanding, if we understand when this happens, that this child is experiencing some stress, which makes sense, right? And then there are things that we can do to help the child, when that. So what do you do to help a kid who's bedwetting secondarily?
Yeah. And if I just step back, that common normal conversation we have all the time. So you're right, Nan. It is common that might happen. Do we accept it as normal? No. And I'll talk about the kids in a minute, but I often say to people who leak a little bit of pee, if every time you ran or jumped or coughed, a little bit of water or pee leaked out your ear, like, would you do something about it? Right? Like maybe that's common, but it sure is not normal. And so that distinction is important.
Thank you for that,
And
Kristen.
yes, really thank you for that, because I see a lot of even, memes and, women making fun of the experience of being a mom, and how, you will never be able to dance without peeing your pants, basically.
I'm 67
and it has been
years old.
normalized.
I don't leak. I've never leaked. Once in a while, if I've had a very full bladder and I laugh really hard, that I needed to go to the bathroom. But I think it's not something that's normal to be leaking. I really
But
don't.
it's being normalized, and it's almost like you're not part of the cool mom club now.
Yeah. It is being normalized. And even when you look at like the commercials about Depends, like a woman in a sleek dress and it looks so good, and we just, you don't even know that she's wearing your Depends. Like we're making sexy the what we do to cover it up. I mean, if we just step back and deal with the actual issue, then she didn't have to wear the Depends, right?
Kristen,
Absolutely.
could you say, there's two things. Could you talk about what you can do for a kid like that? And then Maureen, can you talk about the sling surgeries that people do with this bladder stuff?
I mean,
Okay, I think we
yes.
can talk about both of those things. Okay.
Although I'm not a urogynecologist, but yes, I can.
Oh, you're plenty qualified for this. So how do you help a kid who's having this secondary whatever?
Yeah. So lots of times when kids get into constipation, I mean, in life, kids can kind of control two things. One is what they eat and when they pee and poop, right? And so they hold tension. They decide they've had a bowel movement that hurt, and they're like, I am not ever doing that again. So I hold and hold and hold the rectum, which is supposed to be a sensing device. We are supposed to get poop into the rectum. We hear, our body tells us that we need to go, and we go. And in those kids, they're like, forget this, I'm not doing it. So that because when you think about how tiny that little pelvis is, if you fill up 3/4 of it with poop, then the bladder doesn't have much room to expand. And those kids then have trouble making it through the night because the bladder just doesn't have capacity, and it's getting all this.
So it's constipation related.
A lot of times, yeah.
Yeah. We usually say with kids who are bedwetting, especially if they've been continent at some point through the night, that it's constipation until proven otherwise.
Mm-hmm. Yeah.
Whoa.
As someone married to a pediatrician, I would agree with that.
Yeah. And so then from a treatment standpoint, it's a ton of education with the families, because people never think about, if my kid is wetting the bed, I'm going to deal with bladder stuff. They never think about the
But if you think about it, it's the same with early pregnancy symptoms, right? It's the frequent urination.
Yes. And so we do a lot of conversations about, is your child pooping? And we get them to track and see. We get them to use different positions to poop, like kids that are dangling on a toilet, that their legs are free. So yeah, we do like a stool to support their
squatty potty.
Squatty potty, sure, that helps kids. We talk about doing clean outs, because if the rectum is so full, it just can't contract the way it needs to. So we got to start back to basics. We get them doing time voiding. We look at fluid. There's a lot that we can do with kids with bedwetting. And, I can't even believe I forgot about this. We get them to lengthen the pelvic floor through breathing, through deep squat, through duck walk. So yeah, there's a ton that we can do. And for kids, what we typically focus on is the daytime stuff. And if we can improve their bowel routines, their time voiding in terms of peeing, then the night times usually improve along with it.
So the kid needs some good attention. They
Yeah.
need good attention rather than a parent going like just interpreting this as a, sort of like just an emotional thing and kind of maybe even inadvertently shaming the child.
That's exactly right. And like the kids that come to me have fecal incontinence. And sometimes like there's this actual adaptation that if this is happening a lot, the kids don't no longer smell it even. Right. And so the parents or the teachers will be saying, what is wrong with little Johnny? Because he is having incontinence and fecal incontinence. He's not even telling anybody, but the kids actually don't even recognize it. It's like I say to my parents, like, you know how your nose, like you can see your nose if you look at it, but the rest of the time the brain edits it out. And that happens to with kids that have, quite progressed constipation resulting in fecal incontinence.
Wow, I never knew that.
Yeah.
Thank you.
I guess briefly, sling procedures. So a couple different kinds of incontinence exist. One is like the gotta go. You might know that from commercials. That's usually bladder spasms, and there's a number of different things that can cause that. One of the major things that actually causes it, and you can improve greatly with that, is just using vaginal estrogen. A lot of those women are postmenopausal, and when the vagina, the vulva, the urethra, and the bladder neck are all estrogen dependent tissues, and when you spend several years in deficit, the bladder responds to that lack of estrogen by actually increasing mechanical receptors. So what happens to the bladder is it gets like irritable and does all this crazy stuff. So the people that feel like they have to go all the time, they think they have a UTI, but they don't, although they are at more risk for UTIs. And they have that kind of sensation. That can also, a lot of times that can be improved significantly without medication, which the medications for that are anticholinergics. They have bad side effects for cognition and, can unmask stuff that's neurologically you don't want to do as an older adult. But those, like vaginal estrogen for women, can actually decrease that significantly because it kind of balances that out. The sling is a different kind of treatment for an incontinence. It has more to do with usually prolapse. So like if you're going to leak urine, it can be the pelvic floor. It can also be a dysfunction of where the uterus is sitting, and the bladder sits, and I don't have a good picture even though I'm in my office. The bladder, this is the uterus. The bladder sits here, and we literally when we do a hysterectomy, we literally peel it off. It's separated by a very, very thin amount of tissue. And constipation, bowel gas, everything can press on your uterus and press on your bladder and cause symptoms. But if your uterus isn't sitting where it's supposed to, for a number of reasons, lack of good just tissue that's not muscular is part of it. Sometimes it's your pelvic floor. But if things start to sag and get lower, your bladder can be pulled downward. It's not dangerous, but it can kink. And then you may have incontinence that when you cough, laugh, or sneeze and there's a big Valsalva force, you can force urine out of your urethra. They can fix that to some degree with a minimally, it's pretty minimally invasive, although I've never done one. I've assisted and seen bazillion of them because I don't practice urogynecology, but there's a sling that they can put in the vagina, the upper part of the vagina, to keep and support the bladder neck. This is a uterus, but the bladder is kind of shaped like this too in a way, and the lower part of that, if it doesn't kink and it's supported, you won't have that like forced kind of loss of urine. The one other thing that we didn't talk about, but it's not really relevant here so much, is that sometimes the sphincter of the urethra is the problem itself. And that, interestingly, can sometimes be treated with Botox. But you need a urogynecologist sometimes, or a good gynecologist, or someone who practices that, to kind of differentiate between those things. And the urodynamic testing is another fun thing that we don't really need to get into, but that's kind of where that whole thing comes in. But it does help lots of women.
Yeah, I was on a Ishwish presentation. They talked about the sexual side effects of the slings.
Yeah, can be not,
because it actually goes through the female prostate tissue.
Yeah, they open up the anterior vaginal wall in order to do it, and then use these devices to.
People still don't agree that women have a prostate, and they still don't agree. I mean, it's crazy that how there's so much misinformation, but that they definitely showed in this study that where the sling goes, interrupted some of the prostate, female prostate tissue.
I mean, we're
so.
women in the US, we haven't even really been included in research since, I mean, I was in like freaking high school. So it's not, it's not, it's not been that long. I am not surprised. As a gynecologist, I'm not surprised. I hate to throw, I mean, it's research too, but like there's been very little change in my practice, at least from a gynecologic standpoint. Endometriosis, God, it's so common. We have so little new stuff in the last 20 years. So the whole women's side of things is a whole nother conversation.
And
but,
it's not likely to get better with what's happening.
Not in the next few years, I would doubt it.
Yeah. We won't be meeting next week because Maureen and I will be at Ishwish. So, but I'm looking forward to hearing how people are thinking. I know Ishwish is an international organization, but a lot of the people who are members are American, and I'm just really concerned about, what are we going to do about research?
Yeah.
To continue research. I see some hearts coming up.
Yeah.
And we also have an invitation to move to Mexico, so we're doing okay here.
Yeah.
One of our
and
viewers.
Kristen invited us to Canada, so it's all good.
Yeah. Do you know the one thing that you as Americans have done really well for anybody that's listening at home is that Voices for Pelvic Floor Disorder, PFD, Voices for PFD is a great website that talks about all the procedures. It talks about pelvic floor. It talks about constipation, overactive bladder. It has really good resources for people to understand. Even I do a lot of pessaries too. So if you choose, hey, I'm not having a surgery, but I want a vaginal brace, pessaries are something that can be really supportive too and might help with incontinence. They might help with pelvic organ prolapse. So check that website out, Voices for PFD.
We can add that in the bio of the episode when it goes to YouTube. Kristen, so as we kind of wrap things up, one, blueberry therapy, you're in Hamilton, Ontario, Canada, yay, across the lake. You are the host of the Whole, HOLE, Shebang, SHEBANG, podcast, so you can check that out. She is also putting on the Pleasure Principle conference. I am so excited to go. I'm so excited to listen to the other experts. Like I'm thrilled that this conference exists. There needs to be more of them. So thank you for that. What do you want to leave us with? Since everybody has a pelvic floor and everybody wants to have good sex, what tips do you have for us as we kind of say goodbye?
I think the fact that everybody has a pelvic floor is really important. Like, I love that you're ending it up on that, because we do, if there's something happening with peeing or pooping, or you have low back pain, or you're having issues with sex, a component of it might be a pelvic floor issue. And so advocating for yourself, going to something like that, Voices for PFD, or the Urology Care Foundation, they're really great too. Potentially seeking out a pelvic PT, because we can do so much stuff when it comes to pelvic health, and not waiting. I see people sometimes that they've waited 5 years, 10 years, 15 years to deal with the issue, and we can still deal with it, but it takes so much longer. And then I love just the conversation about breathing. We might be able to reduce some of our issues just by doing some really good deep breathing and not jumping to the, I have something happening, so I'm going to Kegel, I'm going to contract, I'm going to hold, because that may be part of the treatment. But for the lion's share of my clients, especially when emotions are running high, we need to actually reduce the tension in our pelvic floor. I think those are the big.
Thank you. Thank you for coming, Kristen. This has been, I think, a very fabulous conversation, and we'll be back on March 7th for a conversation with the amazing sex therapist, Dr. Holly Wood.
Fabulous. Thank you so much.
Thank you so much, everyone.
Righty.
Good to see
Love
everybody.
you all.
Have a great couple of
Lovely
weeks.
weekend.
And have some good sex and breathe, and you know what? We'll get through this together. We're going to get through this together. Okay. Bye-bye.
Bye.